Hi, everyone. I think we'll get started since it's just about noon. My name is Rebecca Barron. I'm an emergency physician at Bay State Medical Center in Springfield, Massachusetts, and also assistant professor of emergency medicine at UMass Chan Medical School, Bay State. I'm very excited to be facilitating this panel on future directions in gender-based violence research. I have a couple things I just want to go over before we jump into the panel. So we have no disclosures. In terms of the session's objectives, here they are. And then just want to give a little bit of background for this session. So gender-based violence, or GBV, is any form of violence against an individual based on their sex or gender. GBV disproportionately affects girls and women, particularly those who are marginalized in other ways. GBV can have profound and sustained negative effects on health. And conducting research on reducing GBV and mitigating its effects can be especially complex, as we'll see. We are really lucky to have this panel of experts assembled here today. And so I'm going to turn it over to them, have them introduce themselves, their work, and then we'll dive into some discussion. And we will have some time at the end for audience questions as well. So without further ado, I'll turn it over to Dr. Agarwal.
Hi, I'm Pooja Agarwal. I'm associate faculty, associate professor at, How about now? Okay. Hi, I'm Pooja Agarwal. I'm an associate professor at Yale and have been there for quite a while. My primary work was with refugee populations, and I do have a kind of a secondary focus on kind of women, both women kind of within like leadership structures, but also kind of women specifically within displaced populations, marginalized populations, and how some of their challenges have affected their ability to, again, with the lens of refugees, kind of integrate and become kind of active members within the new communities in which they're resettled. And so that's kind of where my answers will probably be within kind of with that light. And I'm excited to hear what everyone else has to say.
Hi, everyone. I'm Annette Decker. Thanks for coming during the lunch hour. I know it's always a little brutal. I am faculty at UCLA. I'm an emergency medicine physician as well. I did a research fellowship there that focused on implementation science. And the bulk of my answers today will be based on a study I've been doing that looks at trauma recovery centers, which is a model for anyone who's been a victim of crime, and it provides wraparound services for mental health and for case management. And the research I've been doing has been using a CFIR framework, so that's called the Consolidated Framework for Implementation Research, and it's a mixed method study, so it's a explanatory sequential methodology where we looked at quantitative data really from patient encounters, and then we did qualitative interviews with patients and providers to kind of expand upon that data. So ended up looking at a little more than 1,600 patient encounters, and then did interviews with 36 providers and about 25 patients. So excited to share more about that.
Hi everyone, my name is Alice Liu. I am currently a fourth-year medical student at UCSF, so very much here to share the trainee perspective of getting involved in this work. And then I'll be starting emergency medicine residency at Mass General Brigham next month. Most of the work I'll be talking about today is the opportunity I had in the last 2 years to build an advisory council for our emergency department. We're out in San Francisco, and there are many domestic violence shelters. We have various hotlines, a very diverse patient population, and so sorting through all of that landscape with our advisory council is what I'm happy to share about.
Hi, my name is Jennifer Newberry. I'm an associate professor at Stanford. The majority of my work centers around kind of one big question, which is how do people connect to care in crisis? So when you are in crisis, how do you seek help, right? And so across the work that I've done, whether that's in global health, primarily in India, or domestically, that's the question we're answering from the participant, typically a survivor's perspective. Right now, a lot of my time is around an R1 that we're doing with the Latina community in East San Jose, looking at mental health utilization, but other work is focused around survivors getting resources during COVID in both the Asian American, and Latina populations, and then working on some future work around kind of the impact of trauma, including TBI and intimate partner violence on folks' imagination and how that affects help seeking.
Hi, I'm Kim Stanford. I'm at the University of Chicago, and my work in this area has focused on human trafficking. I did some work in South America on human trafficking, and then also locally in Chicago. And then I've also done some work around the care for sexual assault survivors in the emergency department, looking at the provision of SAEM exams and how that affects assault survivors. And then the bulk of my work actually is related to sexually transmitted infections, which isn't exactly violence related, but it's sort of intimately intertwined because it ends up kind of being all connected in the end.
So thank you all for your introductions and work. So now we'll jump into some questions. So the first question is, are there any populations that you've found to be particularly vulnerable in your GBV research? And if so, what are the challenges of studying these populations? And how have you overcome them? So Jen, if you're willing to address that.
Yeah. So I would say there's a couple of groups that I would say are particularly vulnerable. I think particularly when we were doing work in India in the global health context, where there just simply were less systems. When we design research, one of the important pieces for us is, what are our backup systems? What are we leaving people with? And so when we were talking with folks from a research perspective, I felt a little bit less supported just because there simply were less systems in the areas that we were. Oftentimes we were very rural areas. And so that, I think, in some ways had a whole other set of vulnerabilities. The other thing that I've encountered in recent years is actually in speaking with folks, noticing during interviews and even during focus groups, survivors who likely also have an underlying cognitive disability or other disabilities that put them at risk. And I think for those folks, hearing how that weaves into their story, but also for me, again, as a researcher, just making sure the conduct of research is ethical and how we kind of bring them into this, because they really are facing dual vulnerabilities there. So those are two that I would mention.
Thank you.
And I'll just add on to that. I think with the population that I'm seeing in LA County, a lot of undocumented women, and I'm sure you all will expand upon that, are particularly vulnerable. One, they're just at a high risk for violence, but once that violence occurs, it's just very challenging for them to get care because of distrust of the system, because of a lack of knowledge of how to even kind of engage with the system, and then also just fear around any legal repercussions. So that with a lot of the interviews we're doing, we kind of see that spiral, and it sometimes takes years before they end up finding a way to get some type of help.
Thank you. And Kim, if you want to jump into.
Sure.
Yeah, and the other thing I would add too is sometimes, especially like thinking about human trafficking, it's difficult for us to identify, and the people who are experiencing it often don't identify it as such. And so to actually be able to engage folks in research is very, very difficult because it's hard to even find them in the first place. And it's hard to also get them to come back, for follow-up appointments if they need them, and to get them to kind of engage in ongoing research studies. So I think having to, something that they don't even recognize that it's happening themselves, or just a subject like an assault where they just really don't want to think about it anymore beyond that time that they leave, not just from a research perspective, but we struggle with getting them to come back, bringing it back to STIs, we struggle with getting them to come back for that follow-up check that they need after they've been given post-exposure prophylaxis, and we can't even get them to come back for that, let alone to kind of engage in research. So I think that's very challenging, and understandably so, because they want to put it behind them the moment they leave the ED.
Anybody else before we move on? No? Okay. All right. So another question. What stakeholders have been or could be helpful to collaborate with in order to engage with the populations that you study? And have you collaborated with, or do you have plans to collaborate with these stakeholders? Alice, if you want to address that.
Yeah, I can talk a little more about our process at UCSF. Like Dr. Stanford was just saying, it would be incredible to get the perspectives of survivors when we're building interventions, thinking about what resources they need, but it's a very difficult group to access. So what we ended up doing was creating an advisory council of the local community organizations. We literally cold called every hotline, DV shelter, mental health resource, including those that serve diverse populations, whether it was undocumented populations or people who spoke minority languages or had family considerations. And through that work, we realized two things. First was that these are community experts as well who give really insightful input into what our emergency department looks like from a survivor perspective. And second is that a lot of people who work in this field are drawn to it because of their own lived experiences. And they've come to a place where they are using those experiences and they're ready to provide that input. And so this was one way that we were able to engage that stakeholder.
Yeah, so when I think about kind of the population that we see in the ED, we're seeing them at a very discrete snapshot in time. And when you think about how they then emerge from your encounter to all of the things that they need when they're trying to kind of move forward and kind of move on with things in their lives and kind of reestablish things in their lives. And that's kind of how I think about where to draw from other stakeholders, where to draw from other individuals that can be helpful both to them and then also to you in your, whatever your research question happens to be. And so I think about it as a very multifaceted process. You think about who you can create a network with and what elements they can kind of bring to the table and help you in supporting that individual, right? So you think about, for example, the psychological support that they need and drawing from social workers and case managers who are within maybe your ED structure, maybe who have groups that are beyond the emergency department within the hospital or even kind of in the community, and their expertise and their ability to engage with your patient who is no longer a patient but is now an individual in the community, and how you can continue to engage with them. I think about kind of when they move forward, what kind of economic independence are they going to need, right? They may need some more support to get them on their feet, to get them a job, to get them the skills that they need to get a job, and what community organizations can maybe help you with that. Are there women's groups? Are there schools with parts of a local university or local vocational center that can also partner with you to kind of engage with those populations? I think about kind of their reintegration socially. So are there support groups, either cultural support groups or just women's support groups, others who have been through that process, and is there a way to use that to bring people to kind of discuss more and to really be more engaged in the work that you do? And then also just thinking about maybe when their first snapshot, when they first see you, and perhaps those are the basic kind of emergency needs that they have, right? Getting together the resources they need to maybe rebuild a home or to, to set up a new apartment or to do something that they're on their feet again. These are all potential partners to look to that might be able to help you in kind of all of the different aspects of the work that we touch on, right? The research is important, but then kind of maintaining the population, finding a ways to kind of help them move forward is also critical. And so all of these partners I find to be helpful kind of in both of those elements. And then also kind of another layer on top of that is partners at both the local level and then kind of bigger than that, right? So you think about people within your hospital, the social workers, the care coordinators who are instrumental in those times of crisis, to your community and those NGOs, those other community partners who have things set up, who have jobs set up, who have vocational programs set up, who have sewing groups, knitting, whatever it is that can help in that support. And then you think about it maybe at a bigger level than that, right? So I'm from Connecticut, which is a small state, but there are resources there. Think about it at the state level. There is Department of Public Health. There is, for my work, the Refugee Health Coordinator, and there are other partners you can engage with that can kind of help figure out where the next steps can be, who else they can draw in from their networks to kind of build this kind of whole community around those individuals and around the work that you're doing.
Thank you. And Jen, do you want to also jump in? Thank you.
I echo, what's already been expressed. I think one thing I would add, just in my experience, and this goes anytime you do work with community partners, is just doing that vetting in the beginning. Because I have had partners that have been more successful because they're a wraparound agency, they're 100% committed and focused on survivors. I've worked with other groups where survivors were a smaller component of their work. And I felt like the infrastructure there to support their work was just not there as much. And so the alignment for the research wasn't there. And so I think, don't assume because they're working in that area or have a program on it that this is going to really work for them. So vetting them as you would any other community partner. I think the other thing just about stakeholder engagement is also being broad about how you're conceptualizing how they may add into the research process. I think oftentimes we're thinking about kind of perspectives for recruitment and things like that. One of the interesting experiences we had last year, actually, for our study that's primarily on mental health, it was some of our community health workers, our promotores, were survivors. And the way that they thought about safety and protocols was very different than every other data collector that we worked with, including other data collectors who were of the community. But their sense of safety, their sense of how they would pick houses was very different. We developed protocols differently. And we had to think, in our group, which also consists of some psychiatrists as well, we talked about, well, what is being trauma-informed from a data collection perspective, and not using that as a way of avoidance, actually, and in kind of the tension that's there as well. And so that was something a little bit newer for me as far as stakeholder engagement, was looking at it even from that perspective.
Thank you. Okay, and next, what changes in practice or policy has your GBV research demonstrated are necessary? And if applicable, what has been your experience with actually implementing and sustaining those changes? I think Kim, you're up.
One thing, we've spent some time looking at whether SAEM nurses, the sexual assault nurse examiners, so their certification to kind of do the forensic exam and the care for sexual assault patients, and whether that actually makes a difference for outcomes. And we did find that it did. It improved the number of people who were offered services and the number of people who accepted the services that were offered during the visit. And so, I don't think that our one little tiny research study has really done anything, but the hope is that if this kind of thing, there's data kind of building up showing that it does make a difference in outcomes, that hopefully that will then lead to policy. In Illinois, we now have a policy that already was being put into place before my paper, so I take no credit for it, but where we're required to have SANE examiners at all times, and everyone's required to have access to a SANE examiner. But there's only a few states that have that policy now, and I would love to see that happen across the country, because we do know that it does make a difference. And so, that is kind of the goal in putting this research out, is put evidence out there so that people who are making policy say, oh, this actually does make a difference. And maybe they don't, making that argument, maybe not from a health outcomes standpoint. Some people care about the health outcomes, but some people may care about meeting metrics that will help with reimbursement, for example. Maybe your hospital administrator is going to care about that. And so if you have data that says, hey, I can meet these metrics, and by the way, if your hospital does this and you meet the metrics, you're going to get reimbursed more, maybe that convinces somebody too. So that's kind of that's one of the goals in doing this research, is to help promote that kind of change.
Thank you. No, I was just going to pass it over.
This legislation is for all hospitals?
Yeah.
Have a seat, every hospital, private or public?
So there you can declare that you don't have the capacity to do it, and you're going to then transfer everybody out. But you either have to determine that your hospital can't do it, and you're going to transfer everyone to a hospital that has SANE examiners, or you are going to say that you're going to have 24-hour SANE.
So I would build a lot on what Pooja was actually talking about earlier. So I think there's kind of two things we've really seen with the research we've done with the trauma recovery centers. One is just that need for whole person care, and so making sure it's not just physical care, but also mental health, and then also social needs. I will say I have there's been a lot of patient interviews where I've done where they said, we'd love to come for therapy, but we can't because we can't get transportation, or right now we don't have a safe place where we're living, or I just don't have the time because I'm working 2 different jobs and I don't have childcare. And so really thinking about how to address those basic needs and social needs to get to the other care that needs to be done. And I think that also goes in reverse. What I hear a lot from the providers is, hey, I sat down to try to provide, case management, but there was so much PTSD that kind of came up with addressing some of these issues that it was hard to fully engage, because we all know there's a lot of paperwork that is involved with getting to some of these social needs. And so having that other component has been important as well. And I think, we see it everywhere. In LA, we are siloed. There's the Department of Health Services, the Department of Mental Health, and the Department of Public Health, and none of them like to work together. And so figuring out how we can really try to integrate that in the system. And I think that kind of brings me to the second piece that I've really seen is figuring out how to provide this care in a sustainable way. So the model that I'm looking at is grant-based. It's from the state, but it's a 2-year cycle. And so you kind of get a year through everything, and then you're stressing about whether or not you're going to get funding. And so that leads to a lot of people leaving because they don't know if they're going to have their job. It leads to burnout. The metrics that they're required to collect don't really kind of fit with the work that's being done. And so I think long-term, using this research to advocate for how to really build this into the system where potentially Medicaid is paying for this or other kind of formal structures so that it's not this wheel we have to kind of reinvent every 2 years.
Yeah, so I actually brought some notes along with me about things that our advisory council told us that could use a little improving after we did an ED walkthrough. So we took them through the patient perspective of what happens when you come in through the ambulance bay, every room you go to, every person who speaks to you, what the environment looks like, and the same thing for if you self-present to the ED. And I'll talk about the themes in buckets of things we were able to address in some way, things we were hoping to address next year, and things that I'd just love to hear, like how does one do that? So things that we addressed this year, they talked about the lack of visibility for resources that are tailored to specific populations. For example, if we have a patient come in, they identify as a transgender woman, and we have our standard, here's what the social worker will give you, this is the packet, this is the main hotline, that we know that there's a very low rate of uptake for that patient to feel welcomed, safe, trusting to reach out to that resource that seems very standard. And so what we did was reach out to all of the community organizations and ask them, what is your capacity like? What if we started listing you as the main referral source when we have a patient of this background? And those who said that they would have the capacity or call us anytime, and if we don't, we have the referral system within our own organization to then send them to the next hotline over. That's what we did. So we went from having just one referral that we sent everybody to about 37 different referrals that are tailored to the primary language. Is it a primary legal need, a housing need? What kind of subpopulation does that patient fall under? So that was something that we focused on this year. The thing we'd like to see next year, our advisory council talked about just the wide variation in types of providers in the ED and the amount of exposure they have to this work and working with this population, the kind of communication training they've had, the de-escalation training they may or may not have had, and also how do you verbalize feeling of safety, of trust, especially in an ED where things don't feel very private. They could be seen in the hallway, in the waiting room when the conversations are started. And also, at least at our emergency department, there's a pretty prominent security presence, and it's not always clear, like, what is that presence there for? What can I feel safe saying or disclosing? And so that's something we're working on for the next year. The things that are more difficult, I think, because they require more funding and hospital leadership buy-in, is it would be amazing. They think if every survivor could come in and have an accompaniment, like one single person who will be there from the beginning to the end of that visit, especially with all the downtime that's involved in the ED, all of the changes of hands, the changes of shifts, the many faces, the retelling of the story, and also having that person be the best trained advocate. This could be someone from one of the community organizations. And we've had a model like that in the distant past, and it ran out of funding. And so it's figuring out, like, how do you create a model like this, use our research to show that it is worthwhile sustaining. And then the other even bigger pie in the sky is this the right place for survivors to be coming always for help? In the same way how we're thinking about having psychiatric emergency access in other settings or other types of emergency access, maybe sometimes what the survivor needs isn't to come into the hustle and bustle of the emergency department, and there needs to be another way for them to access emergency care.
Thank you. All right, and next question. So what are we missing from our GBV research if we only study populations that interface with the ED? And how can we, as emergency physicians and researchers, think more broadly about studying and ultimately helping our target populations? Pooja, if you want to address that.
Yeah, so I think some of the biggest challenges that if someone has kind of come in presented with that particular story, then certainly you know kind of how to address it. I think one of the biggest challenges is even identifying the population, right? Because people are often reluctant to provide the entire story. They don't trust you. Why should they trust you? They don't trust the people that they are supposed to trust, right? And so a lot of it, I think, is even identifying the population, more so in retrospective reviews. If you're doing something kind of looking backwards, and there's no checkbox, right? There doesn't say somewhere, oh, well, this person has this particular history. You have to kind of dig through it or know how to identify them. So I think that's one of the biggest challenges with this kind of work. people are often kind of reluctant to become visible for a number of reasons, because of the retelling of their story, because that's re-traumatizing, because it kind of exposes them to more, to potential from individuals who might be kind of harming them, or might be not as supportive as they need for them to be. And so that certainly is a challenge, and that kind of fear of potential retribution is something you need to be kind of, conscious of and sensitive to. And so those were kind of some of just kind of bringing them out and kind of identifying them is, I think, the biggest challenge. And then once you do identify them, once they've developed that kind of trust, like, that's not a static process either, right? It's dynamic, and things happen in everyone's lives, and conversations happen that set people back, that allow you to kind of go further. And those things are not anything that you can potentially even predict. And so in terms of eliciting the information that you're looking for and trying to kind of establish those boundaries and establish that sense of trust, that's also not going to be the kind of the streamlined process we might see with other populations.
Thank you. And Jen, if you're willing to speak to that also, sure.
Yeah, I'd make a couple additional points. I think there's a couple of groups that we do miss when we only look at ED-based populations. I think we have a bit of an assumption as the safety net of our healthcare system that everybody views the ED as a safe place. And that's not true, especially for folks that are coming from other countries where you don't have a good healthcare system, you don't trust other systems. When people think about physicians, they're not necessarily just bringing to that their experiences with physicians, they're bringing that to their experiences with people in helping positions, or should be in helping positions, like the police. And so we have many people that are simply just not showing up at our door, right? And so I think we do miss folks like that. I also think that just in general, even if we stay within kind of the emergency department population, there is still not enough research on men who experience intimate partner violence. There's not enough research on gender minorities that experience violence, right? And I think we need to be doing better to integrate that. And also, I think in addition, those folks, again, may be seeking their care elsewhere, and there may be other opportunities. And so they're really hard populations to identify. And also most of the screening that we do, screeners that we do use are validated on cis women, right? And mostly cis white women, and there's not a lot of work outside of that. So I think the last thing I would add is also, we typically think of violence as an acute problem. We think of physical injury, we think of mental health, maybe we think about PTSD, right? But violence affects people across their lifetimes. It has an enormous impact on chronic disease, as well as how people seek care over time. I just heard about this really amazing clinic in New York. I think it's called the Purple Clinic. I'm not sure if anybody else has heard about it. It is entirely devoted to intimate partner violence survivors across their kind of health trajectory. So it doesn't matter if they just experienced violence a year ago or 20 years ago. It takes care of them from the perspective of them having survived violence. And I think similarly, if we're only looking in the emergency department and we're only thinking about screening and acute identification, we are missing how that experience of violence is influencing their health in a myriad of other ways and their healthcare seeking behaviors from a chronic care seeking perspective.
And then the last question for now, and then we can open it up to discussion and more questions. So especially in light of the kind of uniqueness of GBV research, what advice would you give to folks who are trying to incorporate this work into their research and academic careers? Annette, if you're willing.
Sure. I think we've probably already gotten a lot of advice from everything you've heard so far, but I think to rehash some of those themes, really emphasizing just the vulnerability of this population, especially in terms of safety. And so I think one thing, when we were doing our research, we weren't collecting any identifiers, but we were doing these phone interviews, and we wanted to send a gift certificate, and we would ask for their address, which was silly of us to do that, and obviously realized that that was a problem because a lot of these women had relocated because of concerns for physical safety. So just sharing their physical address with us was not something they wanted to do. And so really kind of trying to anticipate those, and also pivoting when you come across a barrier like that is important. So I think that's one. I think really thinking about how to do this work trauma informed. And so whether that's how you're doing the interviews, but also which data you're collecting, I think there's a lot of pieces of that. And so making sure your whole team has training for that, and that is part of your lens as you're designing this work. And then lastly, I would say just making sure you are bringing in some type of cultural context and humility, and whether that is through a community organization or kind of checking some of the work that you're doing with someone who has experienced violence and is a survivor, I think is huge, because ultimately I think there's things that we miss as researchers quite a lot. And so having that kind of checkpoint throughout your work to make sure that you are thinking about the questions in the right way and in kind of interpreting them with the right lens.
Thank you. And Kim, if you want to piggyback.
Yeah, I was going to say a lot of those things, so that's great. And I was also going to just add to that, as with really any kind of research that you're doing in a community that's not your own, sometimes the questions that we think are relevant are not the questions that the people that you are studying think are relevant or that are going to make a difference to them. So really to always be guided by the people who work. It doesn't always make sense to talk to the survivors themselves for re-traumatization issues and all of that, but the people working with them can definitely guide you. The people who have been intimately involved in this space for a long time. Make sure that your research question is coming from that community, not just from what you think is important based on what you've learned and from your experience, because sometimes those two things are very far apart. And always being guided by, by the people who already do this work, who have been working in that community with those people for longer than you have, because they will know better than you how to do it in a sensitive way, how to address the issues that are really there, and how to get it done effectively. And those people will be your best advocates, but they will also completely stop you from doing anything if you don't do it right. If you don't make friends with them, if you don't collaborate with them, they will completely put up a roadblock, and as they should. So forming those relationships with people is really, really important.
We have some time now for any questions. Let me bring you a microphone.
See if this works.
Thank you. Thank you all for everything you shared. My name is Leo from UCSF, rising fourth year. To Alice's point on imagining where this care should be received, there's with homelessness and substance use, there's been a response to do street medicine and go to people. What research exists on partnering with women's shelters or organizations like that to bring care to them in those spaces?
Yeah. So for the trauma recovery centers, some patients come from the ED, but a lot come from community partnerships. And so they'll actually have someone that's based in a school or at a university. I've seen that a few times. I've seen partnerships with the police, which is challenging to navigate. But I think when done well, they are often the first on scene. And when they have that relationship where they can refer survivors to those organizations is quite helpful. And then I really think community advocates, I've seen this done well at a couple different sites where it's people who maybe have had a lived experience and then work at the organization and are kind of going to community events and sharing what the services are, and letting people take information in a way where they don't have to necessarily share what's going on at that time, I think has also been quite helpful. And that it also allows them to get kind of a pulse of what's going on and think about whether they should be targeting different partnerships with different organizations.
Hi, I am Aria. I'm an M2 in Detroit. I actually run a nonprofit where I provide mental resources for human trafficking victims, and I'm going into EM, so this is a space I'm super interested in. I guess I'm just interested because I've kind of had a lot of exposure to human trafficking victims, kind of their stories in the ED. I guess I'm interested, Dr. Stanford, on your the trafficking policy that you're creating in the ED. I wonder if you could just speak a little bit on that.
Actually, Annette could probably talk about it too, because she helped me with that. Yeah, I mean, really, the biggest issue, I think, I mean, there's so many parts of this, but like the biggest issue is awareness, right? It's like we can't help people if we don't even recognize what's going on. So that's step number one, is we need to create a policy that kind of lays out what do people need to know about, you know, how to recognize human trafficking, about how to sensitively take care of people when they're suspecting it, what resources are out there and how they can refer people to them. And so we kind of just laid all of that out in a way that, you know, could kind of in a more comprehensive way that kind of laid out all of the things that you need, and then in a kind of outline form of here's what you need to know in like bullet points for when you actually think you're facing this situation, with the goal being to kind of raise awareness, to set out a plan for education, and to make sure people knew how to access the resources that they needed to access if the situation were to come up. And it's really kind of amazing to me how few people kind of know this to begin with, and you know, and even once we got that in place, how hard it was to get people to even to pay attention, to want to get that education, to really like listen to it and absorb it. And so I think just having even the existence of it already elevates the awareness of the issue. So it's at least a step in the right direction from that perspective, I think.
Hi, my name is Hernan. I'm currently a postdoctoral research fellow at the UCLA National Clinician Scholars Program. Thank you all so much for your time and your expertise this morning. I have two questions, and the first one is more general and more of a musing, sort of. And reflecting back on my experiences caring for justice-involved patients, I was just wondering about this special patient population that we may or may not capture in research due to, you know, for lack of better words, logistical and IRB considerations as well, but a huge, potential population that we're missing. So I was wondering if there's any research moving forward in that front, or have you all been aware of any sort of special efforts that's been developed across the sites that you've worked at?
That's not a good sign. Maybe you should do that, Hernan.
Yeah.
Area for opportunity.
Is your question, are there specific populations that have been identified that are not being captured? Is that your question?
I'm sorry for any confusion. I was wondering if there has been any research efforts working with patients who are justice involved, since this patient population is more at risk for various reasons, structurally, also racial, ethnic wise, things like that.
So including them within the research work.
Yes.
Yeah. I mean, I think there certainly is a lot of kind of patient-centered research that happens, and often kind of through like PCORI and other organizations that fund that kind of work. I can't say specifically that I can cite a study, but there is certainly a push to involve community partners, including the populations themselves, within that work as either advisors within your research group to help you understand what are the right questions to ask, what is the right way to ask those questions. And that certainly is an important part. You bring up a good point. It's a really important part of setting up any study, is that you're thinking about all those elements and those populations who might not otherwise be identified and included, but being intentional about including them. So there's a lot of work, I'm sure, to be done still, but it's a great consideration as you move forward with any work you're doing.
Thank you for that. And then my second question is more for Dr. Stanford or anyone on the panel about the curriculum that you've designed regarding your human trafficking policy. I feel like when I was a resident at LA General, a lot of the focus was on clinical medicine and delivering lectures and didactics and things like that, that sometimes introducing threads of social determinants and structural determinants of health have been quite of a challenge. So I was wondering if you could speak on how have you been successful in implementing this as a constant thread in your curriculum, and how has this been sustainable?
It's sustainable through sheer force of will, to be honest, because you're right, this is not... It's something that I think they're interested in, but then like they don't, you have to really kind of force it on people still, unfortunately, in a lot of places. And so, you know, I just talk about it incessantly and I refuse to back down. And so eventually they just let me talk about it in front of people. And I think that's ultimately like what we kind of all have to do, is we just have to be tireless advocates for the causes that we care about. Because if we're not, then who will be? So I don't know that that really answers your question. I mean, essentially, you know, like I try to get in front of people, tell them why this is important, point out the fact that we have, you know, this many people that are, you know, in our area that have been identified as, you know, as having been survivors of trafficking, that there's this many people we think come through the ED. You know, this is why it's important to us. This is how we can make a difference. Please give me a half an hour to talk about it in front of people. And then, you know, you just do your best. And try to really like distill it down to like, what can I tell you that's going to be the most impactful in that small amount of time? You know, like a few minutes on how to identify, a few minutes on how to do trauma-informed exam, on how to kind of provide resources in a sensitive way, and, you know, like where to go to get more information. And then, you know, but don't take too long because no one has any attention span anymore. So it's hard. It's really hard. So I don't have a good answer for you, except don't give up. If you think it's important, just continue to talk about it until people, you know, can't stand it anymore.
I would also add, finding resident and medical student champions who are passionate about this helps with the buy-in in terms of the education at conference or like just on shift. And they kind of bring in their peers too. And so I think that has been helpful whenever possible.
I can add a little what we're doing for the next year training plan. So we have a team of 3 medical students, a couple of residents who have bought in, and we're trying to create a case-based didactic. I think storytelling is a really powerful way to learn and remember. And the stories that the advisory council has shared with us in the last year have been super wild and I think very patient-based. And so we're taking their perspectives and making it into a standardized patient encounter. And I'll see how it goes and let you know.
Just to add, just building off of that, one thing that I have found to be very impactful, and I haven't been able to do this in this particular area, but the other thing that I do is I do HIV and STI screening. And the feedback that I consistently get is what really makes the most difference for people to be engaged and interested is hearing the stories of what has happened in our ED. So this month we diagnosed this person. This is what happened to them as a result of the fact that you guys screened them in the ED. This is how their life is better now. And so like those personal stories, if you can come up with like, this is something local that happened here, this is how we can make a difference and make it better for them, that gets people engaged and helps get them interested in listening to what you have to say.
Hi, my name is Eileen. I'm an intern at UT Southwestern, and being associated with a large academic medical institution, which I think most of us are likely in this room, we do have a dedicated children's hospital, and I'm wondering what work you've done partnering with PEM in order to identify the younger and adolescent victims of human trafficking and gender-based violence.
So I don't work in our children's hospital myself, but we do have an advocate who, somebody who's also interested in this topic who works there as well. But it's essentially the same. We've had the same education that was available to them, same education available to their nurses, same policy that goes for both. And so we haven't done anything specific or different, more just making sure that any education that's rolled out, it's available to them as well, and that it's tailored. So when we did kind of finalize that policy, we tailored it we kind of made a separate section that had kind of stuff that was unique to the adolescent population, that we, kind of developed with the folks who are working over there and who are pediatricians, to make sure that we had kind of appropriate things that would be a little bit different in the case of minors versus adults. But otherwise, it's the same kind of the same education plan, the same way of trying to raise awareness. Not really much different otherwise.
Anybody else? Yeah. So we're launching some new work in the coming years. Happy to connect you with a mentee of mine, Preeti Panda. She is a graduating pediatric emergency medicine fellow with us. She's going to start as assistant professor. Human trafficking is her passion. So the work that we're doing together that she is leading is to develop a comprehensive, how would I describe, kind of intersectional, different types of violence, intervention in the emergency department. So the idea being that human trafficking and IPV and these other pieces, these are overlapping vulnerabilities, right? So if you're catching one, you should be looking for the other ones, right? And so she's doing that completely from the PEM perspective. And so in her work, convening two different advisory boards, one experts in policy looking at human trafficking in adolescents, in pediatrics, and then the other one, community advisory board with folks with lived experience to help us develop those policies and protocols that will then go into our emergency department. So that's work that's just getting started. Happy to connect you. She's amazing. Yeah.
Thank you.
Hi, my name is Rebecca Richards. I work at The Ohio State University. I'm sorry I had a conflict. I didn't get to hear your whole talk. It's been wonderful. Thank you so much. I have experience with our Trauma Recovery Center. I've been a faculty advisor for about 5 years from the EM side. To provide supplemental funding, we were able to get some Office of Criminal Justice directed specifically for human trafficking victims. So I have this funding now, and I'm excited about it, but haven't necessarily had the experience in this space with trafficking specifically. We identified the RAFT as a tool that we might implement more broadly in our ED. I guess I'm wondering, with all of your experience, do you have other recommendations for what I'm looking to do is improve delivery of services for victims of trafficking, which we'll do through the TRC, but a portion of the funding is to improve screening and identification in the ED itself. So any suggestions or advice to point me towards, I would really appreciate.
Yeah, I mean, so screening is a tough question. That's sort of a debated issue, whether like the screening per se works for trafficking. I don't know that I'm convinced that like a screening tool. There's some that people are trying to validate, but it's, you know, like how it's delivered matters, and whether you can actually deliver it in a sensitive way that's going to get honest answers is kind of up for debate. So my personal feeling is that really most of it comes down to educating everyone who comes in contact with the patients. So like your nurses, your physicians, your security staff, your registration staff, anybody who's going to potentially like touch that patient needs to be kind of aware of what to look for and what to do if they have a suspicion. And so I think that's probably the better way of, it's difficult to do that, but probably the better way of getting at it. And so in terms of, you know, how you train them, I don't know that we have sort of one standardized education module. There's a lot that have been created. I worked with, we have a nonprofit organization in Chicago that does a lot of our sort of trafficking, like the coordination of services for trafficking survivors, and they have a presentation, and I actually had them come in and speak, give a bunch of lectures for nurses, and they came and spoke to our residents, because, you know, why reinvent the wheel? They already had, you know, an expert who works directly with survivors who has a presentation, and so she could do that. And so I started with that. So honestly, if you can find somebody that you can partner with locally who knows your local population and can give some of that, you know, like that local kind of the numbers and some, like, you know, some of those personal stories that are from your backyard that can kind of engage people, and then do that education too, can be helpful. I don't think there's like one perfect educational tool. It's more kind of tailoring it to what you think will actually speak to the people that you're trying to address. I don't know if that, yeah.
And just practically speaking, I wonder if staff at the TRC could come to the ED, and maybe they're already doing that. Yeah, okay. But that would be the easiest way to kind of connect those dots potentially.
Yeah, we actually have a really cool program. We have health promotion advocates who are public health workers that are positioned in our ED. So we're doing a lot of specific training with them because we found that they have identified patients, for example, who are at risk for suicide but didn't screen positive on the patient safety screener. And so we know, I mean, we all know when you walk in a room and ask patients some of the questions that are on the raft, they say no, or they don't answer, and maybe you even have that sense that they're holding back, but our health promotion advocates have a lot of success at building rapport and sometimes uncovering those harder parts of the conversation. So we're really excited about the work, but I'm excited to learn and learn from you guys. Thank you.
Hi, my name is Ali Fettigan. I'm a PGY2 at LA General USC. Thank you guys for all being here. This is a really fascinating talk. I'm just curious, especially since one of you briefly mentioned like partnerships with the police, especially when done well, because they can be first on scene. I'm curious if any of you are aware of any research that's being done, or if this has been brought up with the survivors you've talked to about like interactions with pre-hospital providers, or like ways to educate EMS personnel, since those are often the first people on the scene for patients who are coming in by ambulance, or if this is like a space that could potentially be an area of growth.
It's broad. I'm just thinking about all the bias that comes with EMS and with police, and like my mind has already gone 15 steps down the line. I had a lot of reservations when I kind of understood about how this partnership worked with one of the TRCs. And I will say, when I've talked to staff and patients about it, it's done very carefully in terms of how that handoff goes, where police have their office, where the center has their office. But I think getting that kind of constant input from the providers that are working with the patients and from the survivors themselves is quite helpful. I don't think I'm fully answering your question. Let's see if maybe Jen wants to add something, some clarity.
No, I don't know of any educational interventions in the pre-hospital space. I would say it has come up in interviews and focus groups that we've dealt with, and oftentimes it's kind of commingled with stories of also interacting with the police. A lot of the work that I've done has been with immigrant populations, and so it's what I've heard in some of these stories is that interaction, and we know this from other patients, is also complicated by language barriers. So in this mix of violence and injury and calling a crisis service and having somebody arrive, especially, for our folks who speak languages that are not English or Spanish, the access to the language access is horrible. And so then you get on the scene and there's like, I think, a need for people to sort of like, who's victim, who's, like who's the survivor, who's the person perpetrating harm, and there's all this confusion, and then, people are saying different things. And so you just hear how misunderstood and isolated and distrustful that they feel. And I think that does involve the pre-hospital setting, because it is just so chaotic in pre-hospital providers. So I think it would be wonderful. But in our work, a lot of, I think, what happens also does involve like language access, and then also a little bit on immigration. So even for folks who are undocumented, but even for folks who have some form of citizenship, there is so much coercive control that happens in IPV that is around, saying, oh, that's not real, or they'll revoke it, or I'll find a way to get you deported and stuff like that. And so those interactions actually happen, involving these people who represent the justice system, or correlate with that. But we do hear that in their stories.
We're a little over time already, so I'm sorry to cut this short, but sorry it has to end. But I'm happy to hang around for another couple minutes, and if anyone else is able, and I don't have emails up, but if you want to get in touch with these excellent folks, feel free to come up here and we can exchange information. So thank you all again. Thank you for coming, and have a great rest of your day.